Well, good morning, everyone. And I want to thank the museum for welcoming us on a now too chilly May Day, since we've gotten accustomed to kind of rather glorious weather here in New York. And I'm so thankful that someone I admire so much, Chiquita Brooks-LaSure, traveled up from Washington to be with us this morning. And I admire her for many reasons, but particularly for her stewardship of CMS while President Biden was in office. We had the lowest uninsured rate in American history. And she led in, shall we say, quite challenging times, given the COVID-19 pandemic and all the other challenges that predated COVID and certainly were exacerbated by it. But I thought, Chiquita, we could start this morning with you just sharing some reflections from your time as CMS administrator. What are you kind of particularly proud of, and kind of what was the work still left to be done?
Well, let me start by saying how thankful I am to be here with all of you, and just thank you for the invitation. I am so proud of what we were able to accomplish in the Biden administration, and I think so much of why we were able to do so, I would say, is twofold. Crisis can often be a time of opportunity, and I think that the COVID-19 pandemic, I came in when we were in the middle of it. It was before the vaccines were just starting to come. Can sometimes really highlight some key areas, and I think we were able to have a lot more agreement about needing to move forward, needing to move the healthcare system to a better place. And so I look back and am really proud of a couple of things. First, we were able to double the number of people that were covered by the Affordable Care Act coverage, and from 12 million when I came in to 24 million when I left, which is just incredible. I know all of you know just how important it is. I sort of say it's necessary, not sufficient, but necessary to address health outcomes by making sure people have coverage. We were also able to really strengthen the Medicaid program, and I have really been reflecting on that right now as we start entering a period of really having to defend Medicaid again. Medicaid has really changed since the Affordable Care Act, since 15 years ago, where I think it is so important not only to the people who are covered by it, not only low-income people who are absolutely deserving of care, but also it is crucial to the health and safety for the middle class. I think that we can all, I feel like particularly those in Gen X, really appreciate how many people in this country are caring for elderly parents and also have kids who still have needs. And Medicaid has become such a support of kids who have high needs and of people in our long-term care. And so in the Medicaid program, we really strengthened, and I know you all know just how much New York has been able to do with their 1115 waiver, really allowing states to think more broadly about the Medicaid program, and the federal government to set new rules and new standards to really encourage Medicaid to step up and move to a new level. And then finally, in Medicare, getting to negotiate for the first time, it really has changed people's lives. I don't know that people who don't deal with Medicare beneficiaries appreciate how much our nation's seniors are struggling with healthcare costs and struggling with prescription drugs. Some of that is because I think that medicine has changed differently. I remember maybe 20 years ago, if you took 9 drugs, that you were an outlier, that was a lot. But now the average senior is taking 9 medications. And so I just know across this country, so many people were struggling to decide whether to pay for their drugs, whether to pay for housing, whether to pay for food, just the most heartbreaking stories you could imagine. And so being able to negotiate in Medicare and really to change the Medicare benefit because we were able to negotiate has really been one of the things that I'm proudest of and really hope really lasts beyond my tenure.
Chiquita, you just said, many people may not know that kind of the average senior in the United States is taking, 9 medications. What else do you think people, even in rooms like this, where clearly we're choosing to spend time together because we care about healthcare, public health, the social safety net, the social contract of our country, what do you think is still not well understood by people who spend time thinking about or working in this space, or even by policymakers?
I would say a couple of things. I think one of the things that I often feel when I'm talking to various stakeholders is just really understanding the other perspective in the chain. Our healthcare system is incredibly complicated, and a lot of times the incentives are misaligned, and that can be really challenging with trying to solve problems. And I think we have to keep making sure we are listening and understanding other people's perspectives. I truly think that's sometimes one of the single biggest problems in health. And it's really easy. I mean, what I really tried to bring to CMS with the staff is a broader perspective. You have people who work on Medicare and they know nothing about Medicaid, and same with marketplace coverage. And because I have worked on all of those programs, I had a different perspective and a broader perspective, and really tried. We put together a lot of cross agency teams, and I think that's true of stakeholders too, of not sometimes understanding the linkages. And I know you heard Karen and Ani talk a little bit about prior authorization. I cannot tell you how much I think this is affecting our healthcare system. Like the level of frustration that providers are feeling about prior authorization, the level of anger that people are experiencing. And I think that's just one example, and we could go through others. But I think if we have, I talked to, in college, I was at a cancer center when we were announcing new regulations around prior authorization. And nobody goes into cancer saying, I want this special drug. Like that's you're not excited to, take the new sexy drug, right? That is not what's happening. And they were showing me the steps that they needed to go through to get products approved, and the oncologists were telling me they were spending 50% of their time on this kind of thing. It's like, you want the oncologist spending 10% of her time on these actions. And I just use that as one example of like dealing with the friction in the healthcare system is something that I think we really need to continue to address.
And what friction do you think might be more easily addressed? I'm not saying anything's easy, but like if you could kind of equip all of us here with like, here are the 2 things you think we should go kind of think about and advocate for from a policy perspective, maybe from an innovation perspective, like what do you think a couple of examples would be?
I think that there right now is such an opportunity, just a lot of the work that you all are doing about really understanding the linkages better. Certainly as we think about really helping people navigate the system better, this is something that we all need to do in the healthcare system. So really understanding the linkages of how what you're eating is affecting affecting your health. But a lot of times people, it's challenging dealing with our healthcare system, and really trying to make sure that people know how to navigate it, I think is really key. And there's a lot of action around coordinating care, but sometimes we're adding more complexity for people, and so we're like making sure we're keeping people at the core of that. I think we are in a moment where we are in danger of losing the gains that we have, of reaching the lowest uninsured rate, and I am deeply worried about us backsliding. We need to move forward. We need to get more people covered. We need to get everyone in this country with access to care. And so I would say that that is the most important thing in this moment, like really making sure that we continue to make coverage affordable for people and not adding new barriers and new red tape, because honestly, like people are very fed up with red tape in all sorts of ways.
You know, we know there's a lot of red tape being currently discussed right now in Washington, particularly as it relates to Medicaid and especially around work requirements. Could you just kind of share what your experience has been when you've seen work requirements introduced in Medicaid, and if you could sort of buzz into the various members of the different appropriation committees, what would you want them to understand about work requirements?
I think that we've seen two things that really speak to the work requirements discussion. At its core, I think a lot of reaction you hear is, we want people working. Why is this a bad thing to say that people should be working? And that is absolutely a perfectly fine perspective to have. The issue is, should work be related to healthcare? And what we have seen when states have implemented work requirements is that, first of all, there are always people who are exempted. There's always a discussion of, it's not going to apply to people with special needs. Well, often the people with special needs then have to fill out so much paperwork to prove that they meet those exemptions that we lose those people. And just one example, I spoke to a woman who had an adult brother, so she was his not even totally caregiver, but she was the one responsible. She was overwhelmed with filling out his paperwork. He was absolutely exempt from work requirements, but she had to fill out this paperwork regularly, and she's terrified that she's not going to fill it out properly. Then there are people who are working and trying to prove that you meet all of the standards. So think about what's happening, right? You're a waitress and you miss a shift. You take off because you need to take your dad to the doctor, and then all of a sudden you've gone down your 10 hours a week, you're at 8 hours a week, and then you're in danger of losing your Medicaid. And do you have time to prove this every single month? That's what happens. And what we've seen in Georgia could have enrolled an estimated 85,000 people through the Medicaid expansion had they just expanded coverage. In Georgia, there was a strong interest in expansion from the rural hospitals because they were suffering financially. And that's why expansion was approved in the state of Georgia. They've enrolled to date about 5% of people. And it's because the process has been incredibly cumbersome and difficult and people can't get through. Those are just two examples of, I think, what happens when you add barriers. You are not, and there's a lot of data that you don't actually encourage people to work. Most people are meeting the standards that the work requirements require. One of my colleagues, Ben Summers, just released a paper yesterday that breaks down that what they found is basically 5 to 6% of people are the only ones who are not in one of the categories where they're working or in school or a caregiver. So we're spending a whole lot of money to worry about 5 to 6% of the people who would be kept out by these requirements. We're spending millions of dollars on systems, and we're in danger of keeping 95% of the people out of coverage that they need.
Well, that's infuriating. You referenced earlier sort of the rise of kind of a focus on nutrition and helping more people. I think you talked about it in the kind of context of Medicare, but really kind of more people broadly understand kind of how what we eat affects our short and longer term health. And I know, you've often spoken about kind of not only food, but housing and other parts of our lives that are healthcare adjacent. Do you think we should be thinking of them as adjacent, or should we just be thinking of all of these as part of health, of which then healthcare is kind of part of health, but so too are, food and movement and where we live, where we work, where we play?
Yeah, so I think so many of these things are absolutely core to, as an individual, your ability to be healthy. I think one of the challenges for the public payers is how much should be paid for by Medicare and Medicaid, and how much should be paid for by other public entities. And I think that's another reason why making sure we're coordinating is really so key, because there are some things that maybe should be paid for by SNAP, or maybe should be paid for by HUD. And these are things that we have to think about. I mean, one of the issues has been, even as we've expanded coverage in Medicaid and Medicare for these other services, it's affected the eligibility for people for their housing. And that's why, again, I think we have to make sure we're thinking holistically. And it may mean changing some of our core programs, how they operate.
I want to shift gears a little bit and ask kind of for any kind of thoughts or reflections you might have of really kind of what is the role of technology in any of what we've talked about. I know, often healthcare is derided as like, oh, still relying on the fax machine. And there is some truth to that. But also we've seen enormous innovations in healthcare. We were talking earlier about kind of some of the early innovations even in the 90s around kind of electronic payments kind of being a mechanism to actually make Medicaid more efficient. As a parenthetical, I just really want someone from DOJ to define efficiency for me. Like, I want a clear definition. I don't want the, like, you know it when you see it. I'm like, no, that was the Supreme Court on pornography. Like, I just want a clear definition, and I want someone to tell me what the numerator and the denominator should be. So I would like for that to happen. But back to Chiquita. So, where do you think technology really can play a meaningful role in helping, I know, a very complex system be truly kind of more efficient, kind of doing more with greater effect with the same amount, or doing more with greater effect for kind of less cost? Where do you think there are opportunities, for people in this room who might be kind of innovators, founders, investors, to think about kind of where should there be opportunity for tech to engage in a way that maybe it hasn't been part of kind of the conversation historically? Just any thoughts or suggestions or ideas kind of under that broad aegis?
I definitely know and think that technology and AI could be incredible, and is being used in incredible ways in healthcare. If I could start anywhere, I think making our eligibility systems operate better and easier. I'm sure you guys know this, but some of our state systems, some of our federal systems, they're in ancient languages. Do they teach Cobalt and Fortran anymore? I don't know, but I know that some of our systems are in those languages. And it's because states, you come in every couple of years and you don't have all of the money to rebuild the systems and start them from scratch. But I think making some of these transactions easier for all of us would be incredible. And then when it comes to the actual delivery of healthcare, it is crucial that we're able to see what's going on with a patient. I was just with one of my relatives earlier this week at his doctor's appointment, and the doctor could pull up and say, even though I'm not your, I can see when you had your colonoscopy, I can see what the results were. We absolutely need all providers to be able to access all of your records, because people can't remember that my grandfather died of lung disease and emphysema, right? They don't remember every single detail of the family history. And if you as a provider can have access to all of that information without having to rely on the patient to know what they need to tell you, you're gonna get a better result. I think there's incredible promise about diagnosis. You know, there is human error, human bias, and if we're designing our systems to make sure that they are looking at all groups and really including everyone, we can really address, I think, potentially some of the disparities. As you all know, I mean, one of the things we worked on, and Rob Cavaliff and I definitely discussed this together, is just the racial profile, the gender profile of our clinical trials. We need to make sure that we are caring about and really looking. And the Medicare program is predominantly female, and which actually I didn't know until I became administrator, right? So it's crucial that as drugs come to market, that we make sure they work in women as well as men. That's what Medicare is going to care about, right? And so I think that technology can help with some of these things of really identifying gaps, and certainly the idea of getting people to better caregivers and taking advantage. I think when you're a caregiver or a person who needs healthcare, knowing where to get information is really, really challenging. And I think AI's ability to give you information and help you navigate the system, you know, those are a couple of the key areas that I think could be and are starting to be and could be areas of really moving the needle. I think though, and we all know this, but everything can cut both ways. And what we sometimes see when we take a big jump in healthcare or in anything is that the people who are best informed do well, and the people who need it the most are left behind. And we have to be so thoughtful about that because, and I'll say this, right, in the Biden administration, we tried to be so thoughtful, and this was not, of course, just me, it was really my colleagues, CDC and FDA, you know, who are on the forefront of some of the COVID-19 work, but trying to make sure that the people who honestly, I don't say needed it the most, but it was very hard to make sure we had got to the hard to reach areas for people to get vaccinated, to know about it. I went to a community health center in 2021, and I was talking to the leader, and he said, you need to talk to someone 12 times before they'll get vaccinated in COVID-19, right? Like, he was dealing with a on-the-ground, high-risk population, and just saying, like, it's real investment. And I just bring that up to say, even when you're trying really hard, it can be hard to reach the underserved. And so I think my biggest hope and concern is to make sure, as we make these incredible jumps in technology. I met a guy last week who is designing the ability to create different molecules by AI for drugs. And he said there's an infinite number of drugs we can look and test through AI, which is amazing. But I also want to make sure the kid who needs to get vaccinated, the person who has the completely unsexy disease, gets the care that they need. And I think that's what we need to all be working toward as well.
And I think you so poignantly highlight that while certainly we should be maximizing hopefully the promise of technology with clarity around kind of who really most kind of needs it from a patient but also a population level health perspective, you also illuminate that, like, sometimes we just need the human provider to talk to the human patient 12 times. Or I'll never forget the images of the healthcare providers, like, on dog sleds in Alaska, like going to very remote and rural villages because it was not a sufficiently defensible answer to say, well, those communities just have to wait until like the snow thaws. And these extraordinarily kind of heroic and persistent providers, who really did that on the ground work. If you were still at kind of CMS today, leaving aside the questions on kind of coverage and kind of everything else that we've spoken toward, that you would clearly make different decisions on than it at least appears current leadership is doing, where would you kind of orient kind of the innovation efforts of CMS for Medicare, for Medicaid, or the marketplace?
I think when we think about innovation and the Innovation Center, CMS has the ability to do waivers. I think that we have to know that sometimes it really would be okay for us to spend more money. and sometimes when we talk about waivers, and the Innovation Center was put in place as part of the Affordable Care Act. During that period of time, healthcare costs were ballooning and people were really concerned. So there was a real focus on containing costs. And I would say that now, while we are still concerned about containing costs, sometimes we actually need to spend more money on things. And there are, I think, so many core things that we are not spending as a country enough money on, and those would be primary care and preventative care more than anything, right? Like, we have got to get a better perspective about taking care of people before they get sick, not taking care of them when they are already sick, and that is not how our system is designed. We pay way better when you're sick. And so some of the models that we were able to do, one of the ones that I'm so proud of is the GUIDE model, and it is focused on people with dementia and really helping caregivers to have supports so that they can help their family members with dementia, things like nursing home care, to be able to call a nurse in the middle of the night. Do I need to take my dad in, or what do I need to do? And I think like really spending more investment upfront to make sure people get what they need, and being willing to pay a little bit more for that is what I think we need to spend more time on. And that's one issue. Take maternal health. There's so many issues. That was an area of incredible focus for me. There's so many issues, but one of the biggest issues is sometimes women are not going to the doctor and they don't have a relationship till they're in the 3rd trimester. That is not when you want to have a relationship with the provider. You want to have a relationship with the provider 10 years before you got pregnant so that they know you. And then I think that things like that would make such a difference. And so if I could really focus on innovation, it would be, how do we change our incentives to have much more protection and support at the beginning so that we can see better health outcomes over your lifetime?
And to encourage more providers to go into those arena.
Absolutely.
Right? Whether family medicine or primary care or OBGYN care, I think also is a critical part.
Absolutely.
Of this, of the ecosystem of care, and also to have a more kind of prevention first one. I know we're running short on time, so Chiquita, I just want to give you the last couple minutes to share any thoughts that wouldn't have come up in the questions I asked, and kind of what you would want people here to know.
Just to say, I think we really are at this important inflection point right now, where it is important for, I think, policymakers to really understand how important healthcare is, again, not just to the people who are covered by our programs, but it is crucial to our health of the healthcare system as well as our overall economy. We learned that lesson in COVID-19. Like, if people didn't get treated, the hospitals were overwhelmed, and you couldn't get your surgeries, right? We saw what happened. And I hope for our country that we don't forget this lesson that was incredibly painful so quickly. And as we have this healthcare debate again, starting in DC, and the back and forth between the administration and the states, I hope that we really reflect on our incredible gains, that we really need to keep pushing forward on improving our healthcare system and not fall backward.
Well, Chiquita, thank you so much for your leadership and your indefatigableness. I think certainly you could have just like gone and sat on a beach somewhere at 12:01 on January 20th. And I'm so thankful that you're still deeply engaged in this work and continuing to push us to do all that we can to help protect and promote the health of Americans. Could you please join me in giving Chiquita a big round of applause?
Thank you.